Hello, everyone. In this video lecture, we're going to show you how you can use the Solventum, formerly known as 3M encoder, to assign Ms DRGs. Okay, so a couple of things that you will need to know. Whoops. Some key terms, the base rate. This is the rate per discharge for an acute care hospital. This covers the capital-related components, the overhead, the operating components in the hospital. So everything that's considered hospital overhead for that hospital discharge. The CC-MCC exclusion lists, these are principal diagnosis codes that are closely related to a CC or an MCC code that takes away the refinement power of the CC or the MCC code for an encounter. And again, when we talk about CC, we're talking about complication, comorbidity. These are diagnosis codes that, when they're reported, in addition to the principal diagnosis, which we learned was the condition that the patient was seen for after study, right? These things have the potential to impact the MSDRG assignment because it increases the severity. So in other words, if you add another complication, comorbidity, if you think about it, it makes the hospital stay more resource intensive. Therefore, it drives up the MSDRG. And then the grouper. The grouper is what we're going to look at. This is a computer program using specific data elements that assign patients, or in the case of long-term care residents, clients, to groups, categories, or classes, right? So if somebody has an MSDRG, as we'll see, for a hip replacement, as your assignment will do, they will all go into a certain MSDRG. We talked about complication and comorbidities, or CCs. Now an MCC is a major complication or comorbidity. And these are diagnosis codes that, when they're coded as secondary diagnoses, they have the potential to more significantly impact the MSDRG assignment by moving it up 1 or 2 levels. The major complication and comorbidities are the highest level of resource intensity. And then finally, we have the major diagnostic category, the MDC. This is the level in the hierarchy for the hospital inpatient prospective payment system. So in other words, we basically classify these diseases based on an MSDRG, or based on a category that ties to the MSDRG. And based on that MSDRG, that determines how much the hospital gets paid. And back in the 1980s, when diagnostic-related groups came into play, that was fine, but it was felt that we didn't have enough differentiation within each diagnostic-related group. So we had MS, or Medicare Severity DRGs. And basically, this allows payment to be more closely aligned with the resources that are used within each DRG. The MSDRG family is a group of MSDRGs that have the same base set of principal diagnoses, with or without operating room procedures. And this could be 1, 2, or even 3 levels of severity of illness within each MSDRG family. We talked earlier about what a principal diagnosis was in ICD-10-CM coding. And again, that's the reason that's established after study to be chiefly responsible for occasioning the admission to the hospital. You can only have one principal diagnosis. Relative weights abbreviated RW, are the assigned weight that reflects the relative resource consumption associated with a payment classification or group. Higher payments are associated with higher relative weights. So how are DRGs, MS-DRGs, if you will, assigned? They use the grouper. Ours that you're going to get familiar with is by 3M, now known as Solventum. And basically, you have to understand how to group these. This is where accurate coding comes into play with hospitals. Let's take a look at the major diagnostic categories. And again, we talked about these. These are groupings based on body system or other categories. And some examples could be diseases and disorders of the nervous system, diseases, disorders of the circulatory system, pregnancy, childbirth, burns, and so on. And this is discussed in Table 5.2 in your book. The first step is the pre-MDC assignment. Most MS-DRGs are assigned based on the principal diagnosis or a combination of the principal diagnosis and a procedure. But in step one, we're going to look at a specific procedure that's used to assign the MS-DRG instead of the principal diagnosis, or the principal diagnosis and the principal diagnosis and procedure combined. And there's a list of qualifying conditions that include those that are very costly and can be performed for a variety of diagnoses. And of course, with the grouper, we're kind of put away from that. And you can, two good resources in this are Table 5.4 in your textbook and example 5.2 in your textbook. And you can see that here. Over here, we have the principal diagnosis that's used to place the admission into one of 25 of these MDCs. And again, it's all driven off the principal diagnosis. And you can see the MDC determination in example 5.3 in your text. And then we have to take a look at the medical surgical determination. So the big question is, was an operating room procedure performed or not? Appendix E of the MS-DRG definitions manual lists the OR procedures. Some of these OR procedures are not done in the OR, and these include things like bone marrow, stem cell and transplants, and so on. And then, as we can see here, some procedure codes actually group to several MS-DRGs. The determining factor is the principal diagnosis, and this will tell us which MDC this procedure will fall into. Please bear in mind that the procedure does not have to be the principal procedure to influence the MS-DRG assignment. The OR procedure can be in any of the ICD-10 PCS code slots on the claim form, and you can see some of these in this example. And then the last step before we have the MS-DRG assignment is to answer the refinement questions for the MS-DRG. The most common refinement questions relate to whether there's a complication comorbidity or a major complication comorbidity as a secondary diagnosis. And you'll get to see how these influence the MS-DRG assignment when you work with the 3M encoder. And again, you'll see in step 4, the refinement, this is something that we used to spend a lot of time looking about, but as you'll see when you use the encoder, now the encoder will do this for you. Let's take a look at a cardiac defibrillator. So you can see here, right, all of these MS-DRGs are in the same MDC and they have the same primary procedure, cardiac defibrillator implant. So the first refinement question, was a cardiac catheterization performed? If yes, then possible MSDRGs include 222 through 225, as you can see up here. The second question, did the patient have an MI, heart failure, or shock? If yes to any of these, then these would include the MSDRGs 222 and 223. If no, then the MSDRGs would include 224 and 225. You'll notice that 224 is a cardiac defibrillator implant with a cardiac cath without an AMI, heart failure, or shock with an MCC. 225 is the same except without an MCC. And now let's take a look at an appendectomy. An appendectomy with a complicated principal diagnosis with an MCC will fall into 338, as you can see here. The next line below includes MSDRG, and this is an appendectomy with a complicated principal diagnosis and with a comorbidity complication. And at some point, clinicians or other health professionals may ask you why an admission is not grouping to a MSDRG with a comorbidity complication or a major comorbidity complication condition. And most likely this is because of the exclusion list. So how do you know if a comorbidity complication or major comorbidity complication is on the exclusion list? Well, the answer, you need to check the MSDRG definitions manual, which is in Appendix C. So putting this all together, you can take a look at this flow chart. And the step one, see if the procedure is not a pre-MDC procedure. Step two, this one falls in the digestive system, surgical section, so it's surgery on the digestive system, and then we go through the refinement process that we talked about in the previous slides. So an MSDRG without a comorbidity complication or major comorbidity complication, right, will have one relative weight level. If it has a comorbidity or a major complication, this will change the relative weight. And that would make sense if you think about it, because that MSDRG will be influenced by this other comorbidity complication that makes the patient stay more resource intensive. And then the basic reimbursement. We take the MSDRG relative weight times the hospital base rate, and we get the total reimbursement. So in this example, we have an MSDRG relative weight of 2.5729 times the hospital base rate, of 7,500, and then we have the reimbursement of $19,296.75. I hope you found that useful. In the next video lecture, we'll show you how to start using the Solventum encoder and work your way through these exercises. Thank you for listening, and we'll see you online.